You are going to get question not only in theory, but also in practical and viva voce on this scoliosis. So it's a complex, three-dimensional spinal and trunk deformity characterized by abnormal lateral curvature, vertebral rotation, and disturbances in sagittal profile. This is a definition. And learning objective mainly for you, as I said. So this is the most commonest form of scoliosis. If you classify, actually I am talking about the conservative management, but just basic about classification. If you go by the cause, it is congenital, very rare, infantile, juvenile, adolescent or adult scoliosis, out of which the most common is the AIS, account for 80 to 90% of all cases, and as you know, idiopathic, so the cause is unknown. And other significant type of scoliosis include early onset scoliosis before the age of 10 and adult degenerative scoliosis, that is called de novo scoliosis. It is not very common, a sort of rare entity. Prevalence varies across the country, grossly 0.5 to 3% for the curves greater than 10 degree in children and adolescent. The condition is notably more common in females, with the female to male ratio increasing significantly, with the severity of the curve reaching as high as 10:1 for curve exceeding 30 degree. And this is very important. We do the scoliosis screening specifically when their growth spurts occur between age to 10 to 15. And early detection is important because it can potentially avoid the need for surgery. So who and when to screen? For girls, the SRS recommended ages 10 to 12, twice. And for boys, it is once recommended at the age of 10, 12 or 13. And it can be done as a routine screening during the school screening program. And can be done by the doctor by performing this. We all know this Adam forward bending test, where the observer look for uneven shoulder height, one shoulder blade more prominent or higher than the other, an uneven waistline or hip height. The head is not being centered over the pelvis. If there is any such sign, then he might have to go forward with further investigation. This is the Adam forward bending test. You all do in your OPD or during your examination. You've been asked to show how the forward bending test of Adams is being done. So this is the way how it is being done. Patient is asked to bend forward at the waist with their arms hanging loosely and their palms pressed together as if they are trying to touch their feet. And the screener will have to look at the child back from the behind and from the side. From the behind and from the side, both ways. It's not only we are just standing behind and looking at for this hump or this incongruity. From the side you also have to look for this. A rib hump which is prominence on one side of the rib cage, a key indicator for spinal rotation and hallmark of true scoliosis. The foundation of a personalized conservative treatment plan is the early detection. This is the very, very, very important. It will come to, I will talk about it later. And this diagnosis and clinical assessment. The initial sign, as we have discussed, uneven shoulders, hip or prominent shoulders. How you do a clinical assessment of a scoliosis? By a combination of physical examination and imaging. The goal is to identify any structural curve, assess its progression potential, and rule out any underlying issues. Physical examination, look for asymmetry and also check for any skin changes along with the spine, like hairy patches on a skin discoloration, which can suggest a potential underlying spinal cord issues. Neurological exam required to assess for any muscle weakness, numbness or abnormal reflexes for ruling out neuromuscular causes of scoliosis. And the presence of these symptoms can be a red flag, suggesting a more serious non-idiopathic cause of scoliosis. This SMR, skeletal maturity rating, we have to do either the Tanner-Whitehouse, the sexual maturity rating, or Reiser sign, that is the skeletal maturity rating. A scoliometer, it is optional. Actually, I have never used this. In fact, never seen this. But it is written, a scoliometer is a handheld tool similar to a level. And if a reading is saying 5 to 7 degree or more on the scoliometer, it is generally considered a positive screening. Have any one of us ever used this scoliometer? As I have not used it, never saw it in fact. In audience, if anyone has saw it, the imaging. This is the standard imaging technique, a spinal X-ray. The standing spinal X-ray, whole spine, you have to write like full length standing PA X-ray of the spine, taken to visualize the entire spinal column. Nowadays, what our radiologist or radio technician do, they actually combine the pictures. Most of the places it is not available. When you talk to your radiologist colleague, they will say, no, okay, we will combine the segment. But it is not like that. You have to take a single shot, a standing PA view. And if the corpse angle is 10 degree or greater, is the official definition of scoliosis. MRI is typically not needed for a standard scoliosis diagnosis. However, it is indicated for atypical curve like left-sided thoracic curves, early onset scoliosis before the age of 10, significant back pain or neurological symptom, and unusual curve pattern. MRI can help rule out underlying conditions like spinal cord tumors, syringomyelia. CT scan is generally not used for routine scoliosis assessment, but can be used in specific cases for surgical planning, as it provides detailed image of bony structure. So we don't have to write MRI routinely, we don't have to write CT scan. As Joshi sir was saying yesterday, one CT scan means exposure of 400 X-ray. And gold standard is, as you said, this, as I said, the X-ray, that is the gold standard for diagnosing scoliosis. This is the corpse angle. You may be asked to write a short notes on corpse angle. You can be asked during your short cases, and this is how it is measured. The superior border of the upper vertebra facing the concavity, the most prominent angle, and the lower border of lowermost vertebra, and the transection of perpendicular these parallel lines, that is the corpse angle. This is the functional scoliosis, that is there is a structural scoliosis, also there is a functional scoliosis. Now you need to differentiate between these two. So sometimes what happens, there is a leg length discrepancy, and it is referred as functional scoliosis. The type of curve is a basically compensatory response to the body to maintain balance, because due to pelvic obliquity, the shorter leg causes the pelvic to tilt downward on that side. A spinal compensation. Due to this pelvic obliquity, a spine compensate. And it is reversible. A key characteristic of functional scoliosis is that it is reversible. When the leg length discrepancy is corrected, for example, using a shoe lift, the spinal curve often straighten out completely or significantly improve. The vast majority of scoliosis cases are idiopathic. This is a three-dimensional deformity involving vertebral rotation that does not correct itself, and instead the spinal curve itself can sometimes lead to an apparent leg length discrepancy. So scoliosis can also lead to LLD. The pillar of conservative care, detailed analysis and observation. This is the question, watch and wait. What to do? Go for the surgery, go for the intervention, or just watch and wait and do the active observation. For young patient, mild curve between corpse angle 10 to 25 degree who are still growing, the traditional medical approach is watch and wait. And active monitoring, the word is active monitoring. This strategy involves regular checkup and X-ray, typically every 6 to 9 months. When the child is young, you can do 6 to 9 months or 12 months. But if curve is rapidly progressing, then you have to do the X-ray more frequently. Or in adult onset scoliosis, it can be done after this skeletal maturity, even after 1 year. The rationale for conservative management is to halt curve progression, mitigate associated symptoms, enhance a patient quality of life, and conservative treatment are most frequently indicated for mild to moderate curve, typically between 10 to 45 degree. Indication for surgery. This is also a question you face during your examination. When you go for the surgery, it depends on the curve severity. If corpse angle is greater than 45 or 50 degree, then you go for the surgery. If curve progression is rapid, again you can go for the surgery. And if there are symptoms like pain that is severe, not relieved by non-surgical treatment, neurological symptoms like numbness, weakness, and radicular pain, and compromising cardiorespiratory function. Again, these are the indication for the surgery and when you decide for the surgery. So these are the answers for that question, when to go for surgery in cases of scoliosis. Now coming to the bracing, the principle, practice and efficacy. This is a cornerstone for AIS, recommended for cuff angle between 25 to 45 degree in growing patient, and the primary goal is to prevent or halt the curve from progressing. Bracing can be highly customized and designed to apply pressure on the spine to promote realignment and reduce rotation. These are the biomechanic principle, that is prevention of asymmetric compressive forces, reduction of the secondary muscle imbalance, prevention of lordosing reactive forces, and prevention of asymmetric torsional forces, and also to produce dynamic detorsional forces, that is corrective forces. These are the type of braces, rigid braces. These are the most commonly include well-known Boston brace and Rigo Chanu brace. They are typically worn for long duration, that is 12 to 20 hours per day. Is a common conservative treatment for moderate scoliotic curve between 20 to 40 degree. The purpose of brace is not to correct the curve completely, but to stop it from getting worse. This is the short notes you will get during your theory or during your orthosis viva table. This TLSO. They are low profile braces and underarm braces. Effectiveness, the success of bracing is highly dependent on patient compliance. The more a brace is worn as prescribed, it is more effective. This is CTLSO. Always you will get this during your orthosis table. Milwaukee brace. A nighttime brace. These are designed to be worn only while sleeping, but they apply stronger forces to overcorrect the spine. The Charleston bending brace is an example of nighttime brace to provide the better compliance. This is an example nighttime brace, Charleston bending braces. Now coming to the Boston brace, a rigid brace used in conservative management. Work on 3-point pressure system. How it do it? By passive and active correction. What is passive correction? This is the direct mechanical pressure exerted by the brace. The brace is typically custom molded to the patient torso and strategically placed pads and pressure point that apply force to the convex side of the spinal cord. As Dr. Naveen has said, that 3-point pressure system, 2 corrective forces and 1 balancing forces. And active correction. What is active correction? The brace also encourages the patient to actively move away from the pressure. This creates a relief area. Actually, that is called in-bracing exercise. The patient is correcting his posture himself to get comfort from the discomfort produced by the correcting pads. This active component helps the postural awareness and muscle engagement while the patient is still using the brace. This is the Boston brace. As I said, the brace is designed not just to a simple squeeze, utilize the pad effectively to provide a relief area, to give the spine somewhere to go. That's why there are cuts in the braces. You have seen in Boston brace there are cut has been made only to provide that relief by when the patient is trying to actively correct by imposing the muscles. This is the spinal growth also. The primary goal of Boston brace is not to correct an existing curve, but to stop it from getting worse. And also at the same time, it should not prevent the spine from attaining the normal growth. And it also addresses the rotation. The key limitation is the compliance. It's very difficult for the patient to wear it for 18 to 23 hours. And this 2-dimensional versus 3-dimensional, the critics of traditional Boston brace point out that primarily treats the 2D lateral curve, while scoliosis is a 3-dimensional condition and also involves a spinal rotation. So there are newer braces and scoliosis specific exercise are designed to address this. Now coming to this spinal rigidity and muscle weakness, that is due to this is a side effect you can say, or adverse effect of this wearing braces. That's why physical therapy and exercise are often co-prescribed in conjunction with bracing to maintain strength and mobility. This is the Milwaukee brace. A longitudinal distraction is provided as a typical pelvic girdle that fits snugly around the hip and a neck ring with a throat and occipital pad. These 2 anchor points are connected by a metal upright. The tension in the upright create a passive vertical pull effectively, stretching the spine and reducing the curve. So, this is the Milwaukee brace. You can see occipital pad, neck ring and the pelvic girdle. The 3-point pressure system is a primary corrective force and 2 opposing force. This is the most curve point of the scoliotic curve. This is delivered by a pad, that is a thoracic pad. And opposing forces are 1 above and 1 below the apex pad. It also do active postural correction, encouraging the patient own muscles to work against the brace. This is the crucial component of Milwaukee brace function. The pads on the brace are not designed to simply immobilize the spine. They are strategically placed to make the patient uncomfortable. So you can see all the rigid braces are working more or less on the same principle. While doing the derotation, keeping the spine in elongation, and at the same time making the muscle to exercise more and more. This is how it addresses the 3D problem. Three-dimensional deformity that include not only a side-to-side curve but also rotational component, and Milwaukee brace use pressure pad on the ribs to address this rotation. And by applying pressure to the prominent rib on the convex side of the curve, the brace help derotate the vertebrae at the rib cage while fixing at the pelvic side and the occiput side. In summary of Milwaukee brace, it's a longitudinal distraction to lengthen the spine, 3-point pressure system, encouraging active muscular contraction and addressing spinal rotation. So this will answer this short notes on Milwaukee brace, though it is very rarely used nowadays. Other braces are Rigo Chinu brace, progressive action short brace. These we are not used, never used. This Sofrajesco brace. There is dynamic derotating brace set to produce derotating and anti-rotating effect on the thorax and trunk of patient with scoliosis. This is specifically used when the apex of vertebra is T5 or above. This is called dynamic derotating brace. This is again Charleston bending brace. The advantage of CBB is allow full unrestricted musculoskeletal development, allow opportunity for athletic participation, causes fewer less severe complication, result can be assessed without the customary long-term follow-up, and decision making regarding success or failure of the program can be made earlier. This is nighttime brace, and compliance is much more better with Charleston bending brace than any other brace. Nighttime brace, this I discussed. Some are soft orthosis. These are lightweight, flexible undergarment. Strapping system are intended for gentle and passive compression. Evidence of soft bracing, they are considered less effective than rigid bracing. Clinical evidence and success rate, multiple study and meta-analysis support the efficacy of bracing in controlling curve progression. But a meta-analysis of 10 RCT confirmed that bracing significantly reduced the degree of scoliosis in AIS patient compared to control group who did not wear a brace. So soft bracing has only one meta-analysis with a very less this sample, so not much evidence in favor of this soft bracing. But these are the options to just increase the compliance. Success rate of soft bracing as defined as the prevention of surgery vary across a study. It between compared to 53 to unbraced patients. So significantly here in this study, but soft bracing I don't have much this personal experience with that. Now the role of compliance, the number of hours per day the brace is worn. This is directly related to the number of hours a patient is wearing the brace, because every study has found that patient with compliance rate over 90% experience 5-fold lower rate of curve progression compared to those with lower compliance. This is a causal relationship, highlight that the treatment success is not just a function of the device itself, but of the patient consistent adherence. So in this regard, it's your duty and our duty to make the patient show more compliance towards the bracing. Compliance is the basically more challenging thing in bracing than the finalizing the type of brace you are going to prescribe to the patient. Now modern braces are now equipped with eye buttons. They provide objective data on real wear time, and they also give feedback to the patient regarding the correct wearing of the bracing and also the in-brace exercises. Now coming to the physical exercise therapy, a vital component of scoliosis management, and it is crucial to work with a physical therapist who is trained in scoliosis specific exercise. And these are correcting the imbalance where muscles on one side of the back become weak while those on the other side are overexerted, and developing postural awareness, that is teaching patient to be consistently mindful of their posture during all daily activity of daily living and maintain in the correct spinal position. The core principle of scoliosis specific exercises are a set of exercise based non-surgical treatment. They are vital component of conservative care, either as a standalone therapy for mild curve or as an essential component of bracing. These are two methods, Scroth method and a scientific exercise approach to scoliosis. These are basically using a specific breathing technique to help raise the rib cage and improving postural awareness of the patient. Scroth method basically originated in Germany. It is one of the most widely used and studied scoliotic specific exercise method. It's a clinical based approach that requires a significant commitment to a home exercise program. Research has shown it can be effective in reducing Cobb's angle and improving quality of life, with some studies suggesting better outcome when combined with bracing. And this is the Italian method, and other are Lion methods, and this additional PSSE methodology. It's a UK side shift method, Poland Dobomet technique. These are just name here given. Now, what are the evidence for the efficacy of therapeutic exercises? The evidence of efficacy of therapeutic exercises while growing is complex and sometimes contradictory. Multiple sources acknowledge the potential benefit of exercise therapy on Cobb's angle and quality of life. A meta-analysis found a combination of Scroth and Seals to be most effective in improving posture. And these conflicting data can be attributed to a number of factors, including the heterogeneity of the study and a small sample size. So, in a nutshell, we can see to manage the scoliosis conservatively, you need to do routine assessment by doing X-ray at a frequently of 3 to 6 months. You have to manage scoliosis by exercise and bracing. Now you have two choice of bracing, the soft bracing and the rigid bracing. More or less we go in favor of rigid bracing, and depending on the type of scoliosis, the type of curve and the type of progression and type of the patient, whether he is willing to show compliance or not, you can plan accordingly. TLSO is most likely to be show better compliance than the Milwaukee, but Milwaukee has the immense potential to correct, derotate, elongate the spine only if you make the patient to show more compliance. And in bracing exercise technique, the breathing technique, the self-postural correction, all these are very important. And whenever you are doing this physical examination of this scoliosis cases as your short cases, you start from the inspection and tell the examiner or ask the patient, because you need complete exposure of that patient, keeping her modesty in consideration. Unless until you will not able to see the scoliosis. Don't try to examine the patient by lifting his shirt and lifting his t-shirt and trying to say the patient bend forward, something like that. Always tell the correct method how the Adams forward bending test can be done, and always measure this limb length. Despite having this, your differential diagnosis is structural, examiner will be very much satisfied if you do the limb length discrepancy measurement for this limb length by squaring this hip and doing the measuring tape and measuring the entire limb. And if there is any discrepancy, you have to highlight. Again, you will be asked the question how to correct that. And exercise techniques. And these are the implications for available research, that is, despite the clinical acceptance of specific scoliotic exercises, the scientific community has yet not provided the definitive high quality evidence necessary to guide the choice of a specific method. Nobody can say that this exercise is working better than that exercise, or this brace is working than other braces. It's all depends on the ultimately the compliance of the patient, and actually more studies are needed in this field. And this is the take home from my side. This early detection is key. That is the timely screening. In case of girls, I said twice by the age of 10 and 13, and in boys by the age of 12 and 13, single time. And this X-ray finding, again, you have to go through this sexual maturity scale. Tanner 3 is the most common stage at which we finalize whether the growth of this skeletal maturity. For a skeletal maturity, you have Reiser signs. And this clinical assessment and imaging, X-ray is the gold standard. A standing X-ray, whole spine, single view, AP. And if needed, the lateral view need to be taken. And the goal-oriented management planning. And you have to take the patient age into consideration, whether it is school-going age, then you have to consider about the child, because most of these are adolescent kids. they need to follow their school program, they need to take part in the examination, they need to take part in athletic activities and other things. So you don't have to take the patient life away from him because he is suffering from a scoliosis and you want to have the better compliance with the brace that you have prescribed. So everything should be in the balance, and obviously regular observation and a follow-up.
Thank you, Pandey sir, for the awesome presentation. Sir, actually, in our OPD, I have seen a few cases where patient has been operated in ortho department, and they come to us in our OPD as paraplegics. So, and patient party will sometimes ask if the patient is severe scoliosis, if they will ask if the operation is worth it. So, is there any scale or way to identify if the risks will outweigh the benefits? So, or if the patient should go for surgery, or if we should go for conservative management like braces?
Actually, I have shown one of in my slide only indication for the surgery. But what you are asking, that is a very right question. Not one cases, more than 10 to 12 cases we have faced post-surgical complication of corrective surgery, post-surgical complication of scoliosis correcting surgery. The patient are doing bad than what they were previously before the surgery. But it's part of this rehabilitation team and effort. You have to take the patient as it is, because most of the time we see this dislodgement of the hardware and screw. But if you are asking about the indication for the surgery, that I can tell you. And what else you want to ask? Actually, I didn't follow your question.
Actually, the thing is, the persons who are operating,
yes, sir,
should also have a deeper evaluation. Okay? And
yes,
then other thing is that actually complications happen. There's nothing uncommon. The complication will only happen when you will do work. If you don't do anything anyway, the complications will not happen. So complications do happen, and I think it is expected that all the people who are operating on spine, let it be scoliosis or let it be trauma, they also need to have a very clear view what they want, and but it does happen. So regardless.
Actually, I think, sir, he wanted to convey it regarding the choice of surgery and indication of surgery.
I think that's their domain.
Yes, sir,
it's their domain.
Yes, sir, selection of patients. Yeah, this domain. Yeah, their domain.
It's their domain. So
patient went to them and they accordingly operate on it.
You or I will qualify enough to actually comment on that.
But you should be feel yourself very much proud. All of those patients we have, make them recovered and gain many functional outcome after rehabilitation.
This remark was that even after the surgery, brace will be required. So
yes,
that has to be kept in mind.
Yes.
Surgery not the end. Thank you.
Not only brace, the entire training, because most of the time they come to us becoming paraplegic. After surgery, they admitted in a ward as a post-surgical paraplegic patients with lots of pain and other neurological symptoms and signs.
What points we should consider when an adult patient comes with scoliosis as compared to pediatrics?
Adult patient come to with, since you are telling adult patient, okay, so adult patient has already got the skeletal maturity. So it's not about treating the scoliosis. You are actually going to treat the curve. It is causing any functional impairment and any difficulty in his activity of daily living and something like that. You are actually treating not the cause, treating the problem. Usually by the time adult patient, if not operated, that means the curve has not progressed up to that limit. He need any kind of surgery. So if quality of life is not impacted, nothing much need to be done. The postural correction exercises, and if required, bracing can be done, okay, to provide comfort.
So if the scoliotic deformity is progressive, sir.
Okay.
So in such cases, in which side of the body part, whether convexity side or concavity side, we have to strengthen the body part, or in which side we have to strengthen the body part.
Yeah, you have to do the muscular assessment.
Yes, sir.
You tell me which body part you want to strengthen. Obviously, there is muscle imbalance. You understand? You are telling correctly. There is muscle imbalance. Okay, muscle imbalance. That why there you want to strengthen the muscle or correct the muscle. But the muscle imbalance itself is not the cause. There is rotational component also. Okay, so you have to correct the convexity, and again you have to actually 3-point pressure system again. The muscle imbalance need to be corrected in such way the convexity need to be reduced and concavity need to be corrected in a alignment model, in a straight line model.
So same thing, if the patient has underwent the shoulder disarticulation surgery, sir. Shoulder disarticulation, sir. In such case, we have to the same protocol exercise to maintain the balance of the patient for the progression of the scoliosis, sir.
Patient is going through surgery.
Patient underwent the shoulder disarticulation, sir. patient has underwent the shoulder disarticulation surgery.
Okay.
For that, in future,
He's
he
asking
should-
shoulder disarticulation.
Okay.
Okay.
Sir. In shoulder disarticulation, sir, patient in future he will develop the scoliotic posture, sir. For that prevention, we used to go for the exercise plan. In such cases, how will we balance the patient about the exercise? Ki either we have to do the convexity side or convexity strengthening posture, sir.
So what primarily you use to treat? It depends on that. Which is the primary problem? Okay, the shoulder disarticulation or the scoliosis. If a scoliosis is before than the shoulder disarticulation, you are already treating the scoliosis by providing the exercises and providing the orthosis. Suppose a patient with a scoliosis met with a road traffic accident and he has a spinal injury. Obviously, you are going to treat the spinal injury rather than having the patient to do the exercises and bracing. So whatever the urgent and whatever the complication you are giving the more important, that will always take the lead in your this priority.